Hello, everybody. Thank you all so much for joining us tonight. So welcome to everybody here in New York City at our in-person event. And also thank you to everyone who is tuning in virtually with this hybrid program. My name is Kimberly Serota, and I am a program director with the Vision Health Advocacy Coalition. And I'm so pleased to be here tonight with Dr. Lelli and our patient, Fredy Reyes, to talk about thyroid eye disease. So we'll do a quick run through of the agenda for tonight. Let me turn that on. Oh, there we go. Okay, that's good. Perfect. So I'll start off with some introductions, and then from here, we'll do a question and answer with our patient, Fredy, on his experience with thyroid eye disease and treatment. And then we'll go over to Dr. Lelli, who will give a presentation about thyroid eye disease 101. And then from there, we'll open it up for question and answers. So anyone here in the room, if you have questions, please hold those until the end, and we'll have a microphone. We can come around and you can ask questions. For those of you that are attending virtually, at any point, please feel free to enter your question in the bottom of the Zoom bar at any point, and we'll go ahead and ask those questions at the end of this program. So I also want to just say that while we do have a physician here with us tonight, the best treatment and the best answers that you can get about your specific condition is from your doctor. And so we absolutely urge you to seek treatment from your doctor, but we are very lucky to have an expert here tonight to help us with some of those questions that we might have. So this program is also being recorded, and so we will be posting online in the coming weeks this program. So for anyone that may be online that needs to drop off, or anyone in this room that wants to share with family and friends afterwards, this will be available online. So now I like to talk a little bit about the Vision Health Advocacy Coalition. So we promote patient-centered care for policies that make services, devices, and life-changing treatment more accessible for people with vision conditions like thyroid eye disease. Within the Vision Health Advocacy Coalition, we have about 13 member organizations. So all of these organizations, we come together monthly to have a meeting and talk about all of the work that's being done. But the coalition kind of works as a convener of all of these groups to make sure that we are getting the best information about vision health out to patients, to physicians, to family and friends. So this is a list of a lot of our organizations. Within your packet, you can see a lot of the materials that we have put together as part of the Vision Health Advocacy Coalition. Those materials really couldn't be done without the input and help from our member organizations. And for anyone watching virtually, we will go ahead and drop those in the chat and also put them in the follow-up email after this program, so you have access to those. Additionally, in those folders that you'll see is a pamphlet from Prevent Blindness, who is one of our partners, who has a pretty in-depth pamphlet on thyroid eye disease. So please go ahead and check those out. And then also all of these wonderful members can be found online on our website. So you can also connect with us via our website, visionhealthadvocacy.org. We're also on Twitter and Facebook. So if you are active on any of those platforms, please follow us, drop a like, share with your friends and family. We release new materials pretty regularly, one-pagers, blogs, videos. And so by following us on social media, you can really get a good idea of the new materials that are coming out for vision health in general, but also a lot of our new materials that we come out on thyroid eye disease. So with that, I'm going to go ahead and invite our patient Fredy up here so we can start our Q&A. Yep, so we can actually have a seat here. Great.
Thank you.
Yes, thank you so much for being here. So Fredy, can we just start off and can you tell us a little bit about yourself?
Yeah, I am originally from Colombia. I came here to the States to complete my graduate education, and then time passed. I decided to stay here, and my work is it tends to be very technical, lots of time on the computer, and even working with very tiny things. I depend a lot on my vision, and have to be constantly reading and doing things that require my my full visual capabilities. Yeah.
Thank you. So when did your symptoms first begin with thyroid eye disease, and how did it impact you, especially in your day-to-day life and your job, since you rely so heavily on your vision?
Yeah. So just as a little bit of background, my entire family has been suffering from thyroid disease in general, and it's like essentially everybody. When I came here around 2007, I began to have flares of symptoms associated with thyroid disease, and flares of symptoms associated with my eyes. My eyes were all the time red. They were inflamed. They tend to dry up sometimes overnight, and it was extremely uncomfortable. And the solution was, I went to the ophthalmologist repeatedly, and in a single year, unfortunately, I had to go through 4 or 5 treatments for eye plugs. So the diagnosis of the ophthalmologist was, you have your eyes are dry, perhaps the lacrimal, the tear ducts are not functioning well, so they were going to put some plugs to open them and allow the tears to come out. And but it didn't work. And I kept going to the same ophthalmologist, and I was like, oh, okay, well, we'll change them. So in a single year, I had probably like 5 changes of the plugs. And then one day I had used like a general, like a flare up of the thyroid symptoms, and I had the opportunity to talk to someone who just say like, hey, you have thyroid disease, and then you probably have thyroid eye disease. Then I was on thyroid medication, and then at some point in time, the thyroid per se just became normal, but the problem with the eyes slowly continue over time, and it became a situation that people were wondering all the time, why are your eyes red all the time? Like, what kind of activities, additional activities you may be engaging in? Well, there is an anecdote that one day my parents came to visit, and then I took them to the lab where I was working at, and there was a police officer at the entry of the medical school, and then he was just taking notes on like the visitors, and then he looked at me and like, why are your eyes so red? And I tried to explain to him I have thyroid eye disease, and he was like, he didn't believe. But yeah, over time, people people wonder, why are your eyes so red? And then I began to see like the change in my facial structure, and you become aware of that. The possibility of accessing a relatively easy treatment was not there at that time. So you keep having that thing just like hanging, like being with you all the time. As the symptoms, or more recently, I got again flares, and then there was more protrusion in the eyes. But They were like in the mornings, I don't know, like everybody's experience is different, but in the mornings it was really painful to wake up because, the first, reflex is, you want to open your eyes, but then the eyes are dry because overnight, you haven't been able to close them perfectly. So the eyelid sticks to the surface of the eye, and then it's extremely painful to try to open them. It was just like, it was very painful. More recently, just a friend of mine who he's very direct, and he happens, like, his wife happened to be an ophthalmologist too, and then he was just like, "Hey, Fredy, how's your thyroid? This is going." Very direct. But so something happened in all that, like more recently, of course, when the Tepeza became available. It was like, I mean, I didn't realize that I had that, constant, like a little bit of like constant pain, that journey, with this disease. Your eyes are tired all the time, they are dry, they are swollen, your face is changing, and then, there is no apparently easy treatment for that. So, but when Tepeza came out, so I was like, wow, this seems to be really, really, really interesting. So with my wife, we decided to pursue exploring the disease, the treatment, and happened to have the opportunity to meet Dr. Lelli, a fantastic physician, and I am right now in my 4th infusion, and I've been since the first infusion, the eyes began to change, and my like they change differently. One eye changed faster than the other one, but they're catching up. So they're catching up right now, and it's just, it's totally, it's different. I mean, I never wake up anymore with my eyes dry. My eyes are not red all the time. They don't hurt, and it's pretty obvious to the people surrounding me that they change. So I'm very happy about that. It's like meeting again my old self from 20 years ago. Yeah.
That's so wonderful. Thank you so much for sharing that journey. It sounds frustrating.
Yeah.
Trying to figure out the diagnosis. And so my question for you here is, people who are trying to find a diagnosis and feel like they are just kind of keep hitting walls with it, what is your advice to somebody, or what advice would you give to yourself 20 years ago?
Yeah. Well, I mean, it is definitely a disease that is a rare disease, and maybe not everybody is equally trained or have the ability to detect it. But I wish I could have been I wish I could have had a more clear diagnosis about the eye component. For me, it was very confusing, the fact that the thyroid hormones change to normal levels, but I kept having these flares. So I didn't have all the information about how the two things were related. In my mind, I thought they were connected, one and the other. So I was expecting, well, if my thyroid hormone levels are okay, then my eyes should be okay. So I couldn't really explain that. But I think that given the availability of, given the availability of Tepeza, I think it's very important to just kind of like, and perhaps other treatments too, but it's just face the questions right then and there, because over time it becomes like a more like the burden of having the disease, it becomes more clear. And for me, it was, like more recently, it was horrible to be able to read. I mean, I couldn't position the glasses as I wanted because one eye was further out than the other one. And it kept changing sometimes really fast from 1 month to the next. So if you have the opportunity to identify the disease relatively early, or if you find that there are alternatives, it's better to just approach it right then and there. Yeah. So you will avoid that like that burden over time building up. Yeah.
Absolutely. Thank you.
Yeah.
And when you were going through this diagnostic journey, I feel from kind of what you were saying that it takes a toll mentally and emotionally. Can you talk about that, how you dealt with that with your family and with your friends?
Yeah.
Because it is, you were talking about how your face changed, right? So how did you deal with that? How was that experience?
Yeah. So that's a good question. I think that's perhaps I mean, you become like more self-aware about that. Other people notice that, and maybe at the beginning it's like just what I just shared about like the eyes being red all the time, and then people wondering. But when the structure of your face changes, then I would say that that definitely has an impact on your confidence levels and on feeling confident in social situations, and that's not. I mean, that's given the fact that there are solutions out there. And is something that, I mean, you don't need to go through that because you can actually solve it. So I would say like, your confidence decrease, and then also then you begin to wonder like, is this going to continue to the point that your vision is going to be seriously affected? And then now like this disease is not just going to take the confidence, but it could take away like my ability to read for hours and hours and enjoy what I do. I mean, like, what is going to happen with that? So over time, you have an effect on your confidence, but also you have you start worrying more, right? So yeah.
So you talked about how you have been able to use this new therapy. When you found out that there's a new therapy coming out, or that you were possibly a candidate for, what were your emotions? Were you a little bit nervous about it? Because I know it's an infused, so it's not, it's a different method. How did you feel going into that? And what was the difference between your first visit and now your fourth visit?
Yeah. So that's a good question. My initial impression of Tepezza, I mean, even though the commercials, like this is an infusion, I was like, oh, maybe this is like eye drops, and it's gonna be like really easy, because that's what you have done always.
Yeah.
You put eye drops, and actually you could make the problem worse. So I didn't understand the whole, implication that this is a different type of treatment. I had the opportunity to talk again to Dr. Lelli and the physicians at Cornell, and then they describe much better, of course, and in all detail what the treatment is about. And I guess I was perhaps at the beginning I was like a little bit apprehensive. I didn't know if I was going to have some sort of reaction, like a serious adverse reaction or anything of that sort. But I've been very lucky, and when I this is my fourth infusion, and in reality, the secondary effects have been absolutely minimal. Perhaps the day of the infusion, 3 hours later after the infusion, I feel a little bit tired, and that's it. That's as much as been. So So the treatment is, even though it's a different drug and like a different approach, is like not a big deal. Yeah,
That's
yeah.
great. So I think my last question here is, you have talked about your relationship with Dr. Lelli. How important has that been for you to have working with a doctor who seems to listen and care? How has that helped you?
Yeah, so no, it has been extremely important. He is a very, of course, like skill and like has tons of knowledge about the disease, and he conveying his expertise about the status of my disease from the get-go, from the beginning, was really, really, really important. I understand my disease was moderate. It had the progression was not fully advanced, but it was something that needed to be addressed. He has been very supportive. Every single question has been answered, and his knowledge has been perfectly on target with regards to every single thing, the secondary effects, as well as the path and the progression. Having the opportunity to have his expertise as well as the medication, it really has been like change, like something that changed my outlook on things. Because I remember, like, the first time I saw the commercial, I was like, oh my God, there is something that can be done. And then now I look in retrospect, and I was like, I didn't know I was so affected by that. I knew about that I had lost a little bit of confidence in social situations, but I didn't know that I was expecting this so much, that I really wanted to. And I didn't know that I had so many concerns already about the quality of my vision. So having his expertise and his availability and his understanding of how the medication works, and what would be the next steps and in this journey, has been very fundamental, very, very good. Yeah.
That's great. Yeah, definitely urge everybody to find a doctor that you trust and that wants to work with you. And I think I've heard from most doctors that we work with that, if you don't like your doctor or you want a second opinion, all the good doctors will say, go get a second opinion, go make sure that you're comfortable. And it seems like that relationship has just helped you so much. So really love hearing about that. So Fredy, thank you so much for being here with us today. So we are going to have a Q&A at the end. So Fredy will be up here for the question and answer as well. So for right now, we'll have Dr. Lelli come up. I'll do a brief introduction. Thank you so much, Fredy. Appreciate it.
Happy to be here.
That was really awesome.
Okay, so I will do a brief introduction here. So Dr. Lelli is Vice Chair of Ophthalmology at Cornell Medicine, board certified ophthalmologist who specializes in oculoplastic surgery, a specialty requiring 2 years of additional training after an ophthalmology residency focused solely on plastic and reconstructive surgery of the eyelids, orbit, and lacrimal system. So this is when Fredy's talking about the expertise. Definitely went to school and, was able to get all of that expertise, but I'm sure your many years in the field has also helped that. So Dr. Lelli is gained board clinical and surgical expertise while treating patients at Columbia University Medical Center, Manhattan Eye, Ear and Throat Hospital, New York Hospital, Bellevue Medical Center, and New York Eye and Ear Infirmary. So I will go ahead and turn it over to you. Here you
Great. Thank you so much. Appreciate it. Thanks for everyone who came tonight and who is online virtually as well. So Fredy, I first just have to thank Fredy. I mean, that was a great recount of what I hear all the time from my patients. And especially to highlight a few of the things that you talked about. One being how hard it can be to make the diagnosis and how often patients get diagnosed with dry eye or allergic conjunctivitis. and they go from doctor to doctor and they try drops and punctal plugs, and it's not working because diagnosis is different. And there are studies that show that to get a correct diagnosis of thyroid eye disease often takes somewhere between 3 and 5 years for patients, and 3 to 5 different physician appointments. So very, very common. And you also mentioned your family history, which we'll get to in a minute in the slides, but family history is a risk factor. So, if you have family members who have thyroid issues or especially thyroid eye disease, then you want to be a little bit more on the lookout for that. I'm at Cornell now. So the places you mentioned, Kimberly, where I trained in New York City about 16 years ago. And now I'm at Weill Cornell in Upper East Side of Manhattan here. So not too far from where we are. So I will keep this simple. This is really meant for patients and caregivers, and certainly happy to dive deeper into, treatments and science with the question and answer. But I really just want to give you a broad understanding of the disease. So thyroid eye disease is an autoimmune condition, which basically means your immune system is attacking normal structures around the eye and causing inflammation. And that's what causes the disease process. And one of the other things that Fredy mentioned, I'm just going to highlight all the examples because they were perfect, is the fact that he didn't understand why his thyroid had become normal, but he still had thyroid eye disease. And the reason is because they're two separate disease processes with separate mechanisms. And so patients who have thyroid disease, in particular Graves' disease, about half of them can develop thyroid eye disease. But even if you remove their thyroid gland, get rid of the entire gland completely, the thyroid eye disease is still there in most of those patients because of the different mechanism. We'll talk a little about the mechanism, but it gets fairly scientific fairly quickly. So I sort of jumped ahead. Risk factors for thyroid eye disease. The big ones are if you have a thyroid disorder, especially if you have Graves' disease, which typically causes high thyroid levels or hyperthyroidism. Women are affected much more commonly than men, about 4 to 1 women to men. But one of the things we know in terms of risk factors for severity of the disease is it's actually typically more severe in men that get affected than women. If you're a smoker, you're at higher risk to develop thyroid eye disease. You're also at higher risk to develop more moderate or severe thyroid eye disease. So it's a question I ask every thyroid eye disease patient on that first visit: do you smoke? Or if my fellow or resident saw the patient first and they don't tell me, are they a smoker? Then they missed one component that's really important. If there's ever a time to stop smoking, it's if you've got a thyroid imbalance or thyroid eye disease. Obviously, smoking's not good for lots of health implications, but with thyroid eye disease especially. One of the treatments for hyperthyroidism for Graves' disease is radioactive iodine, which is basically using radiation to kind of kill off the thyroid gland. But it's a risk factor to worsen thyroid eye disease. And so if your endocrinologist or your primary care doctor suggest radioactive iodine for your treatment, it's a reasonable treatment option, but make sure you're in the hands of a thyroid eye disease expert ahead of time so that they can take a look, get baseline evaluation for you, and also determine if you have thyroid eye disease. And then most importantly, treat you during the radioactive iodine treatment with some oral steroids, because that decreases the risk that you develop thyroid eye disease. So what does it look like? What are the symptoms that patients experience? The most common thing that you're going to hear are the dry eye symptoms that Fredy mentioned: redness, pain, irritation. They're the same symptoms we get in dry eye because dry eye causes inflammation. And so these are really inflammatory symptoms that are happening. But also the eye is drying out because very commonly the eyelids pull away from the central part of the eye. So the eye is more wide open and the eye pushes forward out of the eye socket. So the eye, again, for a second reason, is more exposed to the air. And so it's drying out, plus all the inflammation from the autoimmune process. And so one thing I commonly hear patients say, and again, Fredy couldn't have said, it's as though you read the textbook. But, is they'll say, it's just, I'm aware of my eyes, or they just bother me. I just know they're there. Now, sometimes they'll be much more forward with it and say, it hurts. My eyes hurt. they hurt to move. But sometimes they don't really know how to express that as easily. And so a patient will just say, I just know my eyes are there. 10 years ago, I didn't think that my eyes are here, but now I just feel them all the time. So those are common symptoms. And one that's not up here, but that I would mention is blurred vision. You know, when the eyes dry out, the vision's not as crisp, and it's harder to do things that you like to do, whether that's, you know, reading or driving a car or working on a computer. And if the eyes don't line up correctly because the muscles behind the eyes are affected from the disease, and thankfully Fredy hasn't had that issue, but it happens in about half of patients, then you can see two images instead of one. Double vision, or the medical word is diplopia. And that's very functionally disabling to do any sort of task. So those are some important symptoms of the disease. So classically, we've thought about this disease as having an acute and a chronic phase. And we still think of it somewhat in those terms, but I will say that as we learn more about the disease, and as you hear stories like Fredy's, the disease never goes away. So it's kind of unfair to say, like, all right, you have active disease and you have chronic disease. I mean, you've had progressive disease for 17, 20 years, you know, and we're finally turning that around. But so every patient doesn't fit into these buckets, but I'm just going to explain to you what it means. Active or acute disease is basically right when a patient is diagnosed. On average, they tend to have many more inflammatory signs and symptoms. And so they have pain, they have eye redness, they have swelling of the face and change in facial structures. And it kind of comes on all of a sudden. And it's like a roller coaster. It can get better or worse day by day, week by week. It can progress over time. And typically that's about 1.5 to 2 or 3 years. The disease sort of burns out a little bit. It doesn't mean that some of those signs and symptoms aren't there. They are. The proptosis, meaning the eyes pushing out, or the eyelid changes, the eyes retracting and seeing more of the eye, they remain. But some of those inflammatory signs and symptoms sometimes decrease at that point in the disease. And oftentimes, for many patients, if they've had the disease for 5 years, they might not change much. They still have the disease and the problems, but they may not have fluctuations on a day-to-day or week-to-week basis. That being said, this is a very heterogeneous disease, which basically means the disease can present in patients very, very differently from one patient to the next. It's not a cookie cutter the same every time. In fact, it's the exact opposite. And so it's not fair to put people in these like simple classifications, because each patient presents slightly differently with this disease and with different components of the disease that are problematic for them. This is just a sort of a diagram so you can get a sense for what's happening. So up on top, we have a healthy eye, and back behind your eye, you have muscles that move the eye up, down, left, right, and even help the eye to torque. And then back behind the eye, you also have fat, a lot of fat back behind the eye. When you get inflammation and when you have an autoimmune process like thyroid eye disease that affects those structures, the muscles swell and they get inflamed. The fat swells and it gets inflamed. This pushes the eye forward. The reason it pushes it forward is because there's nowhere else for it to go. It's surrounded by bones. It's basically in a box of bones. And so the only way it can move if there's swelling is out. The other thing that happens, and the most common thing, is the same inflammatory process occurs in the muscles of the eyelid, the upper and lower eyelid. And when that happens, the eyelids retract. They pull up away from the colored or clear part of the eye, the cornea. And so you see, oftentimes we'll see some white above and below a patient's iris, the colored part of their eye. And I'll show a picture of that in a minute. Now that's the active phase. Years and years later, all of that inflammation leads to scarring. And so now the muscles and the fat become fibrotic or scarred, like firm, and don't work well, don't move well, that sort of thing. And that's the picture on the bottom left, or bottom right, sorry. So this is what a thyroid eye disease patient might look like. And I'm going to save inflammation for the next slide, but these are the 3 most common medical things we think about when we see patients with thyroid eye disease. Eyelid retraction is what I was describing before. It's basically the fact that the upper and lower eyelids, the upper one is pulled too high, the lower one is pulled too low, and we see white around the colored part of the eye. We call that scleral show. If a patient has eyelid retraction, that's the most common thing we'll see with thyroid eye disease. In fact, over 90% of patients who get this disease will have eyelid retraction. So that's a big teaching point I'll oftentimes use, not just for our residents or our fellows, but for like a primary care doctor who might see lots and lots of patients with thyroid problems, is just try to be able to spot eyelid retraction, and then you'll know that's a patient to send to a specialist. We're trying to avoid our patients having to see 5 doctors and wait 5 years for that diagnosis. So that's the most common, eyelid retraction. Proptosis is the second most common. What that means is the eye is pushing out of the eye socket. And again, that's because it's a box of bones and there's nowhere else for it to go. And that happens in about 60% of patients. When you think about the fact that the eye is pushed out and the eyelids are pulled away, that's what causes all that dryness, because the eye is too exposed to the air. And also the eyelids don't fully cover it when people sleep or even when they blink. The blink is not complete anymore. And so when they blink, they don't get a full blink and the eye dries out. So those are the reasons for that. And then diplopia is double vision. That's because the muscles behind the eye either have inflammation or fibrosis. And oftentimes it occurs asymmetrically. One side is affected more than the other. And so the eyes don't line up well. And when your eyes don't line up well, you see 2 images instead of 1. And this can occur in up to 50% of patients with thyroid eye disease. And it's one of the most common ones that patients will really struggle from a functional perspective, because they don't know if they're driving, they don't know which car is the one that they should be avoiding, or is that the curb or is that the curb? And the double's not real simple double typically. It's not like one thing next to the other. It's sometimes diagonal. It doesn't really fit a good pattern. So it can be very troublesome for patients. I mentioned I'd save inflammation. We use something in the office called a clinical activity score to basically grade how much inflammation a patient has. And it's really looking for inflammatory signs and symptoms around a patient. So it's things like pain with eye movements, swelling of the eyelids or redness of the eyelids, redness of the white part of the eye, or redness of the inner corner of the eye. That's an area called the caruncle. We all have this little red bump on the inner corner of the eye, and that can get inflamed. And that's a marker for us of how much inflammation a patient might have. And so the first time we see a patient, we can give a score of 0 to 7. 7 is the highest, and that means a lot of inflammation. And then there are a couple parameters that as we follow up patients, we can add to that score if they're getting worse. But typically speaking, if you have a clinical activity score of 3 or certainly 4, we would consider that to be a pretty inflamed patient. We oftentimes, especially in patients with more severe disease, moderate or severe disease, we oftentimes will get imaging. This is a CAT scan. That's usually what I get. The reason I like a CAT scan is because, one, it's very, very quick test. It takes a couple minutes. It's not scary for some people who are claustrophobic like an MRI because it's wide open, and again, it's fast. And we don't need any injections of dyes through an IV, so it doesn't hurt in any way. These are examples of CAT scans. The first on the left is what we call a coronal view, excuse me. That means like we're slicing the face like this. So we're looking at both orbits, and I don't know if there's a pointer on here. Let's see. Yeah, perfect. So this is the muscle that pulls the eye down. This is the muscle that pulls the eye to the outer side, to the inner side, and up. You'll have to trust me because I don't have a normal one next to this, but these muscles are very, very big on both sides, much bigger than they should be. This muscle here, the medial rectus, is probably 4 times as big as it should be in this image, okay? And that's because of all that inflammation. And then if you look at the axial study, you can see the 2 eyes here, and you can see the thickness that's happening in the muscle here and the thickness that's happening here, and that's the same thing. And one thing that I didn't mention when I was talking about all those medical things we think about when we see patients is that if a patient gets a lot of swelling of the muscles way at the back part of the orbit where everything comes together and it gets very, very tight, it can push on the optic nerve, the nerve that transmits vision. And thankfully, it's a very low percentage of patients, around 3 to 5%, but it can actually cause vision loss, like visual field loss, and even permanent vision loss if it's not fixed in, a reasonably timely manner. And so this is the optic nerve that we're looking at right in the middle. So that optic nerve, that nerve that transmits vision, is in the heart of the action if a patient unfortunately presents with swelling that decides to swell back at the back part of the orbit. So what are we thinking about when we try to treat patients? We want to decrease inflammation, reduce the physical changes that have happened to them, decrease their symptoms, and improve their quality of life. And really all of these things kind of are intertwined. And it involves, seeing what parts of a patient's disease are really affecting them the most and how we can best treat those aspects. Quality of life is very real, and I was glad Kimberly asked about this for patients with thyroid eye disease. There's actually been a lot of studies on this, and one study in particular that I cite is one that talks about a depression and anxiety scale test that was done on patients with moderate or severe thyroid eye disease, a new diagnosis, versus patients with a new diagnosis of cancer. And the scores were similar on both sides. So this is a really big change, a massive change for patients that limits, their quality of life in many ways. Functionally speaking, they may not be able to drive as easily. They may not be able to work as easily. They may have self-confidence issues because of the changes that have occurred in the way their face or their eyes look. And even, patients who have double vision will wind up having the difficulties with eyes not lining up. That can be stigmatic for them as well in social situations. So it's really important to think about all of the aspects, including that one. This is just sort of showing that kind of inflammatory phase at the beginning of this curve where the disease kind of gets worse and changes and then sort of stabilizes out into a static phase 3, 4, 5 years later. The reason I'm showing this slide is because the mechanism of action that's causing all this is related to a specific receptor called the insulin-like growth factor 1 receptor, or the IGF-1R. And there have been studies that show that if you look at orbital fat, the fat that gets involved in these patients, and you look at the biopsies of that fat, that level of IGF-1R is high no matter where patients are in this curve. It can still be elevated, which explains why patients' diseases don't just go away. They might stabilize at a slightly better place, but they often don't just go away. They can, but they often don't. Managing really depends on activity of the disease, and I think most importantly, severity. We try to classify patients into mild, moderate, or severe. And for mild patients, it's simple. It's really fairly simple. And oftentimes they'll get better on their own. There's a large study that showed that selenium, which is an antioxidant, selenium supplementation, helped patients with mild disease just get better on their own. And so we treat patients, really every patient with thyroid eye disease, we recommend selenium for 6 months based on this study. We recommend smoking cessation. We want to make sure patients get their thyroid level balanced with an endocrinologist or a primary care provider. So you need to put a team together. One person is a thyroid eye disease specialist, but one person is definitely going to be an endocrine or a primary care provider. And then we treat the symptoms of dryness, which happen in most of these, most of the patients. And so we have lots of ways to do that. Artificial tears, medicated drops, punctal plugs. If a patient gets to moderate or severe, we start to think about what other options we have, especially if this is a new diagnosis of thyroid eye disease. We sometimes use steroids. It helps with the inflammatory process. It doesn't do much or anything to change proptosis. It can occasionally help with double vision. Patients tend to flare back after steroid use, though, so it's not a great medication. It's frankly not really a treatment, but it can make people better in the short term. I don't really use radiation much anymore. Prior to Tepezza, I would use radiation occasionally. Thankfully, we don't have to put patients through radiation. I haven't used radiation in many years now at this point. Teprotumumab is the long name for Tepezza, and that was approved in 2020 by the FDA, and it's indicated for thyroid eye disease. The reason that this drug works is because it blocks that receptor I mentioned, that insulin-like growth factor 1 receptor. So it sits there and it doesn't allow the autoantibodies, your own body's inflammatory mechanism, it doesn't allow that to attach and create the inflammation that causes the muscle enlargement, the fat enlargement, and ultimately the scarring. And that's why it works. It's given in 8 infusions. Each infusion is 3 weeks apart. There have now been lots of studies on it. There are multiple clinical trials that have been done. There was a phase 2 and a phase 3 trial, now a phase 4 trial that's all been published. Basically shows about an 83% response rate if you define response as improving bulging of the eyes by at least 2 millimeters. And on average in these studies, patients had an improvement of about 3.5 millimeters. In real life, I mean, these clinical trials are what allow us to use the drug and teach us about the drug and teach us about side effects, and I'll talk about those in a second. But in real life, what I noticed with this drug, and the reason that I've transitioned to treating a lot of patients with moderate or severe disease with this drug, is because it attacks the actual process that's causing the inflammation. And so if a patient's main problem is proptosis, the eyes are bulging, but they also have a little bit of double vision and they've noticed some facial swelling and facial changes, there's a very good chance it'll attack all of those components, not just the proptosis. The studies had to pick something that they could measure, but when you see it in real life, it's fluid and patients sort of gradually improve, you know, not all, but most. It's a safe drug to use, but there are some contraindications. It can't be used in pregnancy. In fact, patients need to remain not pregnant for 6 months after their last dose. It might exacerbate inflammatory bowel disease. So I'm very cautious in patients. If they have a history of inflammatory bowel disease, I might not use it on them. It can raise blood sugar in about 10% of patients. So we monitor blood sugar. We know patients that are more likely to get a raise in the blood sugar already have diabetes or have, you know, or borderline diabetics. But we watch that. And there can be hearing changes that can occur in about 10% of patients. Usually they're very mild, like ringing or like muffled sound sometimes. But we have transitioned now to doing baseline audiograms before we start treatment. We do one midway through, or if a patient complains of any hearing issues during treatment. The most common are muscle cramps, actually, and fatigue. Fredy mentioned fatigue, but I'd say about 20–25% of patients get some muscle cramps after treatment. So this is an example of a patient above before, you know, with thyroid eye disease. You can see a lot of inflammatory changes. The eyes are very red. The eyelashes are actually pointing into the eye because the eyelids, the lower eyelids, are swollen. And you can see after treatment, much whiter eyes, less swelling on the lids, a more natural appearance for that patient. There are some surgical treatment options, which we do still utilize, but we tend to utilize them later in the disease process if we need to. Meaning if a patient's had the disease for many, many years, perhaps they've had a treatment course of Tepezza, they've had some improvement, but they still have some issues from the disease. We can do surgical decompression, which basically means either removing fat from behind the eyes or removing bones from behind the eyes so the eyes sink back. We can do double vision surgery, adjusting where the eye muscles sit so that the eyes are straight again and the patients don't have double vision, especially in straight ahead and in down gaze. 95% of our lives live right in front or reading, unless you're like an NFL wide receiver and you need to look like that, you're going to be okay with straight and down gaze. And then eyelid surgery for the retraction is the last thing we typically do. And that's something where we can help to lower an upper eyelid or raise a lower eyelid to make the eyelids look more like they did pre-disease state. Okay, so last slide. Thanks for your attention. So I think, you know, here are the take-home points. If you have a thyroid disorder, you have Graves' disease, you maybe have been diagnosed with thyroid eye disease, see a thyroid eye disease specialist, see someone who takes care of the disease. You can find them. I'll show you a website in a minute that I think has a link by zip codes that you can find them. Make sure you put a team together. It's not just that TED specialist, it's your endocrinologist. It may be some mental health assistance. You know, you may need a thyroid surgeon if you decide to have your thyroid taken out. So there's lots of different components. You may need someone to help you with smoking cessation. So all of those components, but the keys to your team, I think, will be a TED specialist and an endocrinologist. Get the support you need. It may be through, you know, it may be through support groups, it may be through family and friends, it may be through your healthcare providers, or all of the above. Keep the eyes lubricated we recommend preservative-free artificial tears. The selenium supplementation, as I mentioned, and don't smoke, don't start smoking, don't be a smoker. I hope I did okay on time. I wasn't paying attention, but for more information, www.asoppers.org. That's our national society's website. So you can find oculoplastic providers there who are going to be TED specialists, but also information on thyroid eye disease. And then thyroideyes.com, which I believe is the one that's somewhere on there, and I haven't looked in a little while. There's a link where you can actually put your zip code in, and it'll tell you, you know, names of TED specialists in your area. My contact info is there in case you need me, and I'd be happy to hear from any of you. And I think Kimberly wants to open it up maybe for questions.
Yes. Thank you so much.
Thank you.
And Fredy, I'll invite you to come back up. Okay, so we can pull the PowerPoint down.
Where do you want to sit?
Either wherever you want.
You want to sit?
And then I'm gonna unplug this from here just so I can read some questions that come in. Ooh, there we go. All right, so as I said before, if you have any questions online, go ahead and enter it into the question and answer session. Lacey's also here, so if you have questions here, please feel free to raise your hand. We do have a few questions that came in when people registered online, so we can go ahead and ask. We'll start with these, but as anything comes up, please feel free to ask questions. So the first question is, Dr. Lelli, maybe you can help with this. What foods need to be avoided? Nightshade, grains, nuts. Is there any correlation between diet and diagnosis?
Yeah, avoidance of foods. Not to my knowledge in terms of a lot of scientific evidence of things to avoid. The selenium you can take as a supplement. It's also in Brazil nuts. So I have a fair number of patients who, as opposed to taking a pill, would prefer to just add Brazil nuts to their diet. And I've had anecdotally, but again, this is not scientific. Anecdotally, patients sometimes tell me that, you know, going gluten-free for a period of time decreased the inflammatory mechanism, and they felt like it may have helped them. But I don't know of a scientific study on that specifically. So I don't, you know, I don't want everyone to change their diet to gluten-free if they don't want to.
Thank you. We had another question on here. I'm having issues with insurance covering Tepezza. Fredy, do you have any experience with having to go through insurance, or Dr. Lelli, do you have any advice for patients with access issues in general to therapies?
You want me to start, or you want to start? Yeah, it's you know, it can be hard to get Tepezza approved. It does take on average about a month. And oftentimes requires your provider to either do a letter of medical necessity or get on the phone with somebody from the insurance company to do what's called a peer-to-peer review. Basically, their medical director talks to me or the other doctor, whatever doctor's prescribing it. And, you know, we explain why the patient would really benefit from this drug and hopefully get approval. You know, I have had a couple patients not get approved, but for the vast majority, we've been able to get them approved. It just you have to be a little patient. Yeah.
Yeah. So in our case, we have been approved, and we have not had any difficulty with the insurance. But actually, I just wanted to point out that Dr. Lelli and the physicians at Cornell, as well as the people that work with the infusion, which is Horizon. All of them are like really focused on helping. Like in my case, I've been focusing on helping so the insurance process goes smoothly. So
Great
has
to
been
hear.
good. Yeah.
Just wanna okay, that is
Yeah.
great. All right, that's always great to hear. The next question, I am suffering of double vision for 3 years now. I have now prism in my glasses and it helps. Would surgery be an answer? And so obviously just
Yeah,
general,
generalization. Yeah, sure. It's all, you know, we always have to examine a patient to really know what the best option is for that patient. But yeah, 3 years of double vision. So there's a few options for double vision. One option, the simplest, it's not a good long-term option, is to patch one eye. If you don't have both eyes working at the same time, you won't see double. Obviously, we hate that option because you lose a lot of other things when you can't use your other eye. The second option is prisms and glasses, and those are basically like ground in. They're made special to allow you to see single, again, usually in straight and down gaze. The problem with thyroid eye disease is that one, the misalignment is oftentimes a little atypical, and the prisms kind of work in like 2 dimensions. It's not easy to get like a diagonal torsional problem fixed with prism. And the second is that sometimes the strabismus in TED patients changes. You know, they progress or they get a little better, and so they've spent a lot of money on these prisms, and now they need a different set of prisms. Surgery is an option for sure if a patient has been stable in terms of their measurements for usually 6 months minimum. And I would say Tepezza is also an option potentially. You know, I don't know if this patient already had it, but in the clinical studies for Tepezza, it improved diplopia in 70% of patients, and it resolved it in about 50%. So, you know, also something they could think about. But yeah, one of those options.
Great. This question is coming in for Fredy. How many more infusions do you have left? And will you have to have any treatment afterwards? I don't know if you know the answer to that second question, but.
Right. So I still have 4 infusions more, and they are done every 3 weeks. And so I see the changes already. They are significant. And I don't know what would be there.
Yeah, I mean, I think, you know, just speaking generically, not even just Fredy, but after a patient completes treatment, we usually like to wait about 6 months, and we like to see how everything settles out and stabilizes, and then determine if there are any residual factors that need treatment. For most patients, you know, there still will be some component of dry eye just because you've had it for such a long period of time. So probably most patients are using some lubricating drops or some treatments for dry eye. And then, as I mentioned in the talk, occasionally, you know, we'll still have a patient who needs something else done. The most common thing is eyelid surgery. You know, for most patients, if they need something, it's just that, you know, a little bit of that retraction is still there, and we want to fix that. So those are the more common things.
Great. This question, I'm not sure that we'll have all of the answers for this one, but I'll go ahead and read. What do you think of clinical trials for novel drugs like linstidnib? Do you know what I'm trying to say there? Okay, for TED, any positive news? Also, when can Canadian TED sufferers expect Tepezza to be approved? I don't know that you have the answer for that last one.
So the last one, I definitely don't have the answer for. I mean, that would be a question to Horizon, the company, if they have a timeline for, you know, different international availability. There's so many factors involved. There are other drugs that are under investigation. And there are some that are similar in terms of their mechanism, blocking the IGF-1R receptor. There are also, they're not approved yet, but the trials look relatively promising so far, still fairly early. There are also some trials through Horizon and a couple other companies looking at different ways to get the drug to patients. So meaning not an IV infusion, but an injection maybe instead, like an injection into a muscle or into the subcutaneous space. So a little bit easier than having to get the IV. And there's a different study looking at even a pill form of this. And then there are a few other mechanisms that are being looked at that are a little more in their infancy at this point.
Great. Is double vision or unbalanced eyes related to having prisms?
They kind of go hand in hand. I mean, if somebody has prisms, they probably got them for double vision. So it could be that the double vision is causing the imbalance, or it could be that their prisms are a little off.
Let's see. What do I do if TED comes back after TED surgery? I don't know what kind of surgery. Can patients sustain 2 or multiple surgeries?
Yeah, so yes, the short answer is yes. Patients can have more than one surgery. I will say, actually, prior to 2020, the way we managed this disease, which was terrible, really, was that we waited until they got to that static phase of the disease. So we basically handheld for 3 years until everything was kind of fibrotic and scarred, and then we did surgeries. And oftentimes patients would have many surgeries. They would maybe have, if they had really bad disease, they might have bone removed behind one eye, wait, heal, bone removed behind the other eye, wait, heal, maybe strabismus, double vision surgery, wait, heal, eyelid surgery, wait, heal. And now we're talking another couple of years to get all those accomplished. So in the past, patients had a lot of surgeries. I think now it's less likely that they need multiple, but occasionally patients need a couple surgeries. Yeah.
I might need your help on this one too. So I have
Hashimoto's?
Hashimoto's thyroiditis. Does having telangiectasia
Telangiectasia?
lead to thyroid disease? Thank you. Sorry.
Yeah, that's okay. I mean, telangiectasia is like little vessels, so that would not be related to thyroid eye disease, but Hashimoto's disease is. So Hashimoto's is an autoimmune thyroid problem that causes low thyroid levels. And so it's sort of the opposite of Graves' disease. But what I didn't mention is that of all thyroid eye disease patients, 90% or so will have Graves' disease or high thyroid levels at some point, but about 10% will either have totally normal thyroid the whole time or Hashimoto's, which is kind of common. So if you have, that's why I sort of said, if you have any thyroid issue or disorder, it's worth getting the eyes checked, because someone with Hashimoto's could develop thyroid eye disease.
So those are all of the questions that we've gotten online. Is there any questions within the room?
Sure.
Oh, we have a microphone. Do you mind using that so we could?
Oh, so the people on Zoom can hear. Yeah.
I'm sorry.
Yeah.
So actually 2 questions. One is related to thyroid. So once you have a thyroid imbalance per se, does it automatically develops into the eye disease? Number one, and number two, does every eye ophthalmologist do a test, just like glaucoma?
Mm-hmm.
Yeah, coma. Now every time you go to the eye doctor, you get a coma test. You'll find, even though you have high blood pressure, there's no glaucoma, so there's no relation. So how does one compare to the other? That's the first one.
Yeah. So the thyroid disorder doesn't directly lead to thyroid eye disease. It's a risk factor, that's all. And they're 2 separate disease processes. And the most common or the highest risk factor would be Graves' disease. So high thyroid levels, diagnosis of Graves' disease, up to half of those patients might develop thyroid eye disease. But it's confusing, even to me still, having done this for like almost 20 years, that there's still 2 separate diseases. And so while they kind of are risk factors for each other, they don't necessarily run into each other and, turn in. The second question about, like, can any eye doctor kind of look for thyroid eye disease, I think was the question. The answer is they should be able to. We're all trained in this, to be able to see eyelid retraction, proptosis. But I will say that it's really hard, because if somebody comes into my office where this is all I do, I just do oculoplastics, and so maybe see 250 TED patients a year, we're really attuned to just looking for that. If someone comes into a general ophthalmologist or an optometrist's office, 95% of their patients have blurry vision, need glasses, dry eyes. It's just not the thing they're doing all day. So that's why I think if you have risk factors for it, you can always just ask your eye care provider, hey, I'm a little worried about this. Do you think I have any TED signs or symptoms? Or if you're not sure, could you send me to somebody who could check for that? Sure.
So, what do you recommend for the parent, for a child with disability, not knowing, just looking at the symptoms, especially if the child is almost nonverbal. I mean, he cannot express.
Mm-hmm. With thyroid eye disease?
Yeah.
It's tough. I mean, obviously, very difficult situation. I will say, I think managing symptoms as best you can. You can also look for objective signs on the exam. The eyes are objectively dry on the examination, so we can treat that. Even if we're not sure if somebody's in pain or not, we can still treat it because we objectively have a sign. Or the eyes don't line up correctly. We can objectively know that and either treat it with a prism or even just, patch an eye for a period of time and see if any function improves for that patient. I will say, make one comment, generally speaking, that Tepezza is not an option for children. So the studies were all done in patients 18 or older. The main reason is because you can slow growth in somebody who's still growing if they get an insulin growth factor receptor inhibitor. So thanks for the questions.
So I have another question here. Oh, we can go. Actually, while she comes to you, I'll just ask this one question. Do you need to see a TED specialist or a neuro-ophthalmologist?
Great question. So there are the two most common ophthalmology specialties that will take care of TED are either oculoplastics or neuro-ophthalmology. Sometimes strabismus surgeons get involved, and that's just because of the double vision, but it's usually oculoplastics and neuro-ophthalmology.
Okay, and then in person.
Hi.
Assume for this question that the chief complaint is of the patient is double vision. And the patient had recently a second infusion of Tepezza, which showed mild improvement. Do you think, in your experience, do the subsequent infusions result in an exponential improvement in the double vision, or would it simply maintain the same level of improvement?
Yeah, in my experience, every patient's different, but in my experience, you really need to take all 8 infusions to get the full benefit of the drug. I've had a few patients, very few actually, stop early, and more so for logistical reasons. There was Operation Warp Speed back when COVID was rampant, and they took over the plants for COVID vaccines, and so we had to stop some patients. And while some of them did okay, I did have one that kind of had a pretty strong recurrence, not getting all the drug. So I've seen patients continually improve. I've seen patients go 4 infusions with no change and then improve. So I've really seen the gamut, and I don't think 2 is enough for sure to really know, especially if you already had improvement after 2. That's a great sign. I usually tell most patients, the average patient, like my average patient, after 3 infusions usually is noticing what this is working. And you notice after 1, I remember you told me, but which is really fast because the first dose is a half dose. So.
Fredy, can you add on to the way you felt after each infusion? And
Yeah, so in my case, the left and right eyes, they were protruded differently. And one eye has been more easily treatable. So after the first infusion, my left eye just like really retracted a lot, and it was very obvious at home. And then the right eye has been like moving back slowly, but I mean, I think good.
yeah. So we have another question online here. Any suggestions for at-home care or remedies for symptom relief, including pain and dryness? I have mild TED, so doctors are hesitant to push for any treatment like steroids or Tepezza, but the pain can be so debilitating for me. And at what point do we consider TED mild or more moderate?
Okay, yeah, two good questions. So for dryness, there are a few options. One I'll mention at the beginning, which is there are actually experts for dry eye as well. So if you're struggling and you can't quite get comfortable, it is a very complicated, although very common problem. And so you can see a dry eye expert. Those are usually cornea specialists. But that being said, some simpler remedies that sometimes work. I'm sure you've tried many of these or are doing them, but preservative-free artificial tears, lubricating gel before sleeping in case the eyes don't close all the way, like Genteel gel is a very good one. I tell my patients, especially during the winter time when the heat is on, to run a humidifier in the room they sleep in to increase the ambient humidity of the room. There are medicated eye drops for dry eye, things like Restasis and Zedra and Cequa that can be used to decrease the inflammation. And so that's a good option. And then there are punctal plugs, tiny little plugs that we place in the tear duct drain that allow your tears or tears you put in the eye to stick around longer. So those are the sort of standard components. And if you've tried all those and you're still struggling, then I would probably see a dry eye expert for other options.
And then,
and the second
yep.
one was mild versus moderate. So everyone's classification is going to be a little different. Because we don't truly define it, but mild patients typically are younger or middle-aged. They have, as their signs and symptoms, mainly just eyelid retraction and dry eye. So, and sometimes they get better on their own just with time, but those are the main symptoms. Moderate patients usually have a level of proptosis, the eyes are bulging out. They still have the eyelid retraction, and they may have strabismus double vision where the eyes aren't lining up very well. And then the severe patients are the ones either that are losing vision because there's compression back behind the eye on the optic nerve. Those are certainly severe. Or they're the ones with really bad strabismus, really bad proptosis. Maybe the proptosis is so bad that their corneas are drying out so much they might get a corneal ulcer. Those would fall into the severe category as well. Some risk factors we think about, the biggest ones are males, older patients, smokers, radioactive iodine we mentioned. But one that I didn't mention is acuity of disease progression. So if I see a patient on day one and I classify them as moderate and I say they have double vision and proptosis and eyelid retraction and dry eye, and then I see them 4 weeks later and they've developed into compression of their optic nerve and everything's gotten way worse, the double vision's gotten worse, the eyes pushed out a lot more in a 4-week time frame that's really short, and now the progression is too fast, and so they would fit into severe.
Great. So I think that is all the questions that we have online and here in person. So I would like to thank everybody for joining us virtually and in person. And absolutely, we'd like to give a round of applause to Fredy and Dr. Lelli. Thank you guys so much for coming and sharing your story with us. I know that can't always be easy, so we really appreciate you coming and sharing your experiences. And Dr. Lelli, that was a fantastic presentation. Just really appreciate you being able to break this down for us. So just want to say thank you to everybody. We collected emails, I believe, when people registered, and so we will be sending a follow-up email to everybody in attendance with some of our resources and also a link for this program as well. And you also have Lacey and I's contact information, so please don't hesitate in reaching out to us with any questions you may have. But just want to say thank you again so much to everyone for participating tonight, and I hope everyone has a very